I'm proud to introduce to you our first speaker of the morning. Dr. Robert Kidd is a graduate of McGill University, practiced emergency medicine for 10 years, and has conducted a medical consulting practice in Renfrew, Ontario for almost 40 years. He has published extensively in peer-reviewed literature, has written a textbook of neurotherapy, and writes a monthly neurotherapy e-newsletter for physicians and dentists. He has lectured at conferences on a variety of topics for over 30 years in Canada, the US, Europe, Australia, and South America. Please give a warm Academy welcome to Dr. Kidd.
Thank you. Good morning, and just so I don't forget, I've been instructed, and I don't mind reading. I do not have any financial interest of a product in my talk or with any company offering grant monies for this continuing dental and medical education program. So, first of all, a thank you to the organizing committee, Rick Fisher and my friend Pierre LaRose from Montreal, for offering me this invitation to come here. This is an organization, I've come to meetings here before, and I go to a lot of, my medical interests are quite broad. I go to many different organization meetings, and I've always had a special place in my heart for IAOMT for a number of reasons. One is that I do work with dentists a lot in my practice, and the second is that I think that this organization achieves a very nice balance of good practical clinical medicine, dentistry, and science. I've always been impressed how you've been able to attract good scientists to this organization. So it's, I have many reasons for wanting to be here. I think we can, I've got 1 hour, and the timer starts right now, I believe. So we're going to begin with, first of all, explaining, why I use the word occult. This is not witchcraft. This means, the occult here means hidden. So we're talking about the type of pain that you meet in dentistry and in medicine, affecting teeth and the face, and for which there's no obvious cause being found. Or it's pain which you've tried to treat and you haven't succeeded. You've done that root canal, you've done the dental extraction, etc., and you still have the pain. This is not about referred pain. There we go. Wait a sec. That's number one, and it's not working. Help, help. Okay, I'll do it here. Okay. Just to mention it, we can get referred pain to teeth from trigger point muscles, and I'm sure most of you know these. The masseter muscles, the temporalis muscle, and the anterior digastricus muscle can all refer pain to teeth. There are other muscles as well, but this is a totally different area of neurophysiology, and I'm not going to talk about that. In fact, I'm going to tell you what I'm going to talk about right now. First, some basic neuroanatomy. There won't be very much, there'll be just 2 slides. Then the heart of this lecture, I would say, are the neurophysiological principles, because understanding these and everything else follows. Now, these are mostly classical neurophysiology. The second, third, and fourth, I'm sure most of you are familiar with. You probably covered it in your physiology and in your dental training. And it's fairly common knowledge, although not always applied clinically. Tissue memory is a different thing. This comes from classical neurophysiology, but it's not very well known. In fact, our pain clinics would do well to know something about this because it's something that we run into every day. But the only school of medicine that I know of that has paid any attention to the concept of tissue memory are the neural therapists. And I'm going to talk more about that later. But I'm going to be spending quite a bit of time on tissue memory because I think this is something new to most of you and has tremendous clinical application. And then I'm going to talk about neural therapy. Before I leave this, how many of you use neural therapy in your practices? Fair number. How many of you know nothing about neural therapy? Even more. Okay. So we can't avoid the subject, but I won't spend too much time on it. Okay, the basic neuroanatomy is promised. This is a busy slide. There's only two things that you need to know from this slide. One is that the red lines, those are pain sensory fibers. So the ones we're most interested here are the lower two branches of the trigeminal. They go through the trigeminal ganglion, they go into the pons, then they backtrack into the upper cervical spine, and they synapse here. Some of them crossing over on the other side up to thalamus, some of them going up on the same side. Thalamus is pain central, so that's where the pain processing occurs. The only other thing you need to know, besides the fact that these are the pain fibers, is that there are synapses. There's synapses down here, and then there's some here. And synapses are important because that's where the signals are modulated. They're upregulated or downregulated. So that's where the action is in neurophysiology. Now, the second slide, you don't need to remember anything here except that descending pain modulating pathways exist. This has been known since the 1960s, Melzack and Wall's work. There are signals coming from the cortex, the hypothalamus, and so on, which come down, meet the signals coming up, and modulate them. So this is a very much of a mind over the perception of pain process. And this is fairly well known. This has been standard neurophysiology for the last 40 years or so. Now, what is less well known is that pain can be modulated in the periphery. They can be modulated at the nociceptors and at the autonomic ganglion. And in fact, here is an example. We have the middle branch of the trigeminal nerve, and innervating, of course, the teeth, the sinuses, the inside of the nose, and so on. And we have this autonomic ganglion sitting right here, connecting in with these other fibers. And as we know, autonomic ganglia control circulation and salivation and secretions and so on. But what is less well known is the autonomic ganglia can change the proprioceptive signals. I was a little surprised yesterday speaking to someone here who I felt would know this, but he did not know that there is such a thing as neurogenic pain, neurogenic inflammation, and the autonomic nervous system acts on that. So we're going to talk a little bit more about that soon, but I want to also mention in the lower jaw, again, this is practical stuff for you folks as dentists. We have the submandibular ganglion connected with the lingual nerve, again, controlling secretions and circulation, but also modulating pain at the periphery. Then we have, there are other autonomic ganglia, but these are the important ones. The stellate ganglion. All your sympathetic fibers innervating the head and neck come from the thoracic spine. They have to pass through the stellate ganglion. And then we have the middle cervical, this is also called the inferior cervical ganglion, the middle cervical ganglion, and the superior cervical ganglion. Now, the superior cervical ganglion sits right behind the tonsillar bed. It's less than half an inch, very, very close. And some of our speakers yesterday were talking about the importance of the tonsils with regard to the teeth. Well, here is where there's a lot of information collected. And I sometimes wonder whether the location there has something to do with connecting with what's going on in the tonsils. Now, you'll see there is a little bit of literature on facial and dental pain, this occult facial and dental pain. They don't call it occult. And you'll find some of the pain clinics have had some success in treating these by blocking the stellate ganglion. But I don't think they really understand what they're doing, and I don't think they do a really good job, because what they use is high concentration local anesthetic with preservatives. Often they're using steroids and things like this too. And none of these things work as well as real neural therapy. We're using dilute, very pure procaine. So, to summarize what I've been saying before, we can modulate painful sensory inputs centrally, but for the purposes of this lecture, and practically, what we're going to concentrate is modulation of the pain at the autonomic ganglia and the nociceptors. These are both reachable with our techniques. Now, as promised, tissue memory. The concept of tissue memory comes largely from the work of A.D. Speransky. He was a Russian physiologist, a protege of Pavlov, and between 1925 and 1935, he ran a big, very well-funded research institute in Leningrad. He and maybe a dozen or more other really top-notch neurophysiologists worked there. Most of their experiments were done on dogs and cats and rabbits and so on. Obviously well-funded. During this period, it was the golden period of neurophysiology in Russia. They led the world. Unfortunately, in 1935, the Stalinist purges began, and that institute pretty well closed. Now, fortunately, Speransky, in 1934 in Russian, 1935 in English, wrote this book called A Basis for the Theory of Medicine, which not only covers all the research that was done in that lab over 10 years, but also brings up some theoretical challenges to the practice of medicine. In my view, this book is one of the most important medical books of the 20th century, but it's very hard to find now. I did a recent search, and even Abe Books doesn't have it. Last I looked, you had to pay $900 for a copy. Now there's none. However, there is a publishing company in New York that reprinted this about 4 or 5 years ago, and you could get a copy, a soft cover copy, for about 20 bucks. It was published by international publishers. They're still going. You might be able to get one if you phone them up. Now, this publishing company is owned by the Communist Party of USA. Believe it or not. Speransky was purged by the communists. He almost lost his life after the Second World War because he didn't hold the right views. They practically made a martyr of him, but now they can make a little money selling his book. Now, what did Speransky have to say? Well, this is pretty central to his theories. First of all, the disease is not just the opposite of health. Although you may have bad health as a result of it, and it may be part of the reason the disease began, but it's not the same thing. Second thing also is true, it's not a disturbance of normal physiology. Disease is a new process. The Argentinian author wrote a recent book and he called it "The Body Makes a Disease." Now, how does it do that? Well, Speransky found that the nervous system is central to every disease process. We knew there was a connection back as early as 1906 when Spice demonstrated that procaine, which we know has major effects on the nervous system, was also an anti-inflammatory. But Speransky goes farther, and he shows that disease, including inflammation, is directed by the nervous system. In fact, he did many experiments which showed how the nervous system was involved with the disease. First of all, he came up with the concept of irritation of the nervous system, which is something more than just a strong stimulus. Irritation of the nervous system sets up a process. It's a dynamic process. And like all dynamic processes, it does follow certain rules, but you don't know where it's going to end up. It's like forecasting the weather or climate change. You don't know where it's going to end up. It's characterized by a latent period, sometimes just a few hours, but sometimes several weeks. And this is something we see in clinical practice all the time. A good example would be failed back surgery. Person's had his surgery for his sciatica, and it was successful, and things look great, and 3 or 4 weeks later, the pain comes back. So the neurosurgeons start repeating their MRIs, and they're looking to see what have they done wrong, what's happened, and so on. What's happened is this process began during the surgery and comes to the surface a few weeks later. It arises at one point, intensifies, and spreads through a segment, and if it gets bad enough, it will spread right through the body. It may not. It may only go a certain distance and then regress. It may have a rhythmic pattern, and we see this in many medical conditions where people have waves of pain or waves of illness come and go. The pattern can only be changed or arrested in the early stages, generally speaking. But you never know. So it's always worth looking when you see a person with a fulminant disease, still look for that irritation, because occasionally you can correct that and correct the disease. And I mean serious diseases. And when this process starts, often the condition will regress, the symptoms will disappear, but the tissue memory remains in the system. And here is an experiment that shows this. He did hundreds of experiments, and I'm just picking out this one because I think this is to neurophysiology and clinical medicine. It's an extremely important experiment. This is to neurophysiology and medicine as the double slit lamp. Double slits is to quantum theory. You know, the experiment where they shine a few pulses of light and through the double slits, and under certain circumstances you get a wave pattern, other circumstances you just get dots. Well, that is affected by the mind, and scientists have been working on that experiment for 80 years. This is one we should be looking at now in medicine because it's not being applied. Okay, this is the experiment. They got a healthy dog, injected one of the hind legs with a sublethal dose of tetanus virus, and what happened was some localized tetanus. Not enough that it spread through the body, but the dog would have spasms in the leg, and after a few weeks it would recover. So they send the dog back with the rest of the gang for a few months. Then they'd pull the dog out, and then they would irritate the nervous system somewhere in the body, not necessarily in the leg. And what would happen is the leg would start to spasm very slowly. It developed tetanus, then it would spread through the whole body, and the dog would die. Now, if that doesn't blow your mind, it should, because it blows my mind every time I even think of it. They went on to do it with many other dogs. They did it with other diseases. They did it with rabies. They did it with diphtheria and so on. In each case, they created an illness. It was in the nervous system. The germs were gone. They were long gone. Then irritating the nervous system somewhere. And the kind of places they would irritate was they'd cut a nerve on an opposite side of the body, or they'd break a tooth, put a little bit of formalin in it, or they'd implant a sterile glass ball in the brain. Wherever they irritated the nervous system, the tetanus would start in the leg where the initial injury started, spread through the body, and the dog would die. Okay? So this one, if you don't remember anything from this morning, remember this, because this is worth thinking about. You're going to see applications of this in your practice all the time. Okay, practical applications. Think of the conditions that we see over and over again, like migraine headaches. Okay, when a person gets a migraine headache, it's usually very characteristic for that person, but it can be triggered by all kinds of things. It can be triggered by perhaps change in the barometric pressure. It can be triggered by beginning to get a bug. It can be triggered by maybe some dental work. It can be triggered by an emotional event or change in emotional strength. The migraine tissue memory comes back and they experience a migraine. Same thing, people who get, say, a severe pneumonia early in life, they'll often say that whenever they get a cold, it always settles in their lungs. It comes back all the time. Well, what's happened there is they have a tissue memory in their lung of what pneumonia is like. So any sort of irritation when their immune system gets depressed, that pneumonia will, or pneumonia-like symptoms will come back. Okay, now Speransky had no real explanation for this, but we do know now that there are permanent changes in the nervous system when certain experiences occur over and over again. We know that the metabolic pathways in the postsynaptic autonomic fibers become upregulated. Tyrosine hydroxylase is involved, and it seems to be through an induction at a genetic level of the messenger RNA. So we know there's biochemical evidence of tissue memory. Okay, now we're going to go to one of the other principles that I think most of you know about, summation. That's the addition of more than one neurological input to reach threshold level. In other words, the input may be inadequate to reach threshold, but when combined with other things, it does reach threshold. Of course, summation was shown way back in the 20s or 30s, but more recently in studying pain conditions, we found, for example, that lumbar spine, single spinal sensory nerves will respond, sometimes it takes more than one input from periosteum and ligaments and so on to register a pain signal. So this is well worth keeping in mind for those people who tend to specialize in one area of pain relief. You know, you get the trigger point guys. They think they can treat everything by treating trigger points. They'll get a lot of things that'll work, but very often the trigger point sensory input is summating with something else, and that's what's limiting their success. So put it in visual form. Say this is your irritable tooth. It's not irritable enough to cause pain. It's not reaching threshold. But you have another tooth nearby, perhaps with mixed metals, or has had a painful experience in the past, or perhaps there's a sinus that's irritable, or maybe a temporomandibular joint that's not working properly, or somatic dysfunction of the maxilla. When those are added together, you reach threshold. Or sometimes you need to have 3 inputs to reach threshold, depending where the threshold is. So when looking for sources of pain, it's always important to look for more than one source. Very seldom is chronic pain from just one source. There's usually a summation with other inputs. So what can we do about this for our poor patients? Well, I mentioned yesterday that yesterday discussing with someone in this audience, they hadn't heard of neurogenic inflammation. I thought this was better known because it's been around for at least 25 years. I haven't put in a reference for that reason, but it's the concept that sensory afferents do not just send signals to the central nervous system, they also release pro-inflammatory neuropeptides where the nociceptors are. And to balance that, the autonomic nervous system releases other chemicals which can modulate that. So we have norepinephrine and substance Y, both can modulate the nociception at the peripheral level. In other words, the autonomic nervous system can regulate the gain of nociceptors. So as clinicians, when our patients have pain, we have 2 strategies we can use to help them with their pain. One is downregulating the nociceptors, and I've given you some examples there, but we'll get into the practical side of it soon. The other is increasing the pain threshold. You remember remember the lines, the threshold lines, those can go up and down. So how do we do this downregulating at the nociceptive level? Well, a lot of this is dentistry, paying attention to dental and extradental mechanics, so good bite, good temporomandibular joint function. Get your nearby osteopath involved. If you've got chronic pain and it isn't responding, get a good osteopath to make sure that the maxilla, mandible, the facial bones are all sitting comfortably and moving properly. Look at all those aspects of periodontal dental health that you do every day. And a third option is neural therapy. We'll get to that we're getting to that soon. Now, increasing the pain threshold. This is, you were covering some of that yesterday in the functional medicine and so on. We need to support our patients nutritionally. Pay special attention to vitamin B12 and magnesium, but there's many others as well. Try and reduce the inflammation, especially through diet. I found I see a lot of chronic pain patients. I always ask them what their energy level is. And if they rate their energy level at 6 or less, I will spend maybe a month or 2 or 3 or more dealing with their energy level, meaning their nutrition, before I even try to start the pain. They're just not going to respond if they're exhausted all the time. Detoxify, especially in the mouth. We know that anybody who's had amalgam in their mouth, they have mercury in their gums and bones, and it's there for a lifetime. I had my amalgam fillings replaced 20 years ago. I still struggle with mercury. I have to watch it. I see it, and lead too. We see this whenever you're doing a dental procedure, even if people had their fillings out 20, 30 years ago, there's going to be a terrific release of mercury when you do anything involving the gums. I've seen people get really sick after a dental procedure. I think I have enough time to tell you this story. I had this woman in her early 50s, a very bright professional lady, who came to me with fatigue, mostly fatigue, some memory loss, and so on. So we quite easily identified it being a mercury issue. So I had her go to, maybe it was Dr. LaRose, I forget. She was from Montreal. And we went through detoxification using chelating agents and many other things. And after about 6 months, she was feeling much, much better, and her mercury excretion was down to very acceptable levels. She was feeling so good that she went off to her dentist to have an elective dental procedure done 2 months later. Immediately after that, she felt exhausted. It felt exactly like she had been before she'd had her amalgam fillings removed. So I got to see her again. Now, her mercury excretion with a DMPS challenge, when I'd seen her in June of that year, was down below 5. When she came after this dental procedure, I did a challenge, and it was 150 or something like that, like a huge excretion of mercury. And the only thing that had happened was a minor surgical procedure in her mouth. So in your chronic pain patients, this is very important. Try and help your patient get their sympathetic tone and cortisol levels down, largely through lifestyle, getting enough rest, quit their job if necessary, and so on. All of these things will bring your threshold up. So we're working on these. We're also trying to bring the threshold up. And now, as promised, we're going to start on some neural therapy. Take a little break here. Okay, first let's define it. And there's different ways of defining it, but the one I like best, and that's why the title of this talk, is that it's a medical system of detecting and treating local disturbances of the body's electrophysiology. I don't think this is the entire thing, but it's good enough. It'll look after 95% of the neural therapy that we're going to do. Neural therapy was a system that was developed by 2 physician dentists. Someone yesterday mentioned the ideal situation for biological dentists would be a system where you got a medical training first and then specialized in dentistry. Well, that's been the case in Germany for 100 years. These 2 gentlemen, they were brothers. They were dentists, and that's mostly what they did, but they were the ones who discovered the concepts that they developed into what we call neural therapy. This has become so big in Germany, it's not, most of the time it's not a part of the medical curriculum, but it's generally taught and learned right after graduation. In Switzerland, it's now a part of the medical curriculum. There are thousands of physicians in the German-speaking countries, and in the Spanish-speaking countries, tens of thousands of physicians doing neural therapy, and dentists, many, many dentists. One more definition, interference field. This is the technical term for that little focus of irritation that Spransky called an irritation, where there's a disturbance, a local disturbance of the body's electrophysiology. You might think of it as being analogous to an ectopic focus in the heart or the brain. We all know of ectopic focus in the brain causing epilepsy, and ectopic focus in the heart causing fibrillation. You can have an ectopic focus in any tissue in the body. They just don't display themselves in as obvious a way as in the heart and in the brain. Another phenomenon in neural therapy is that pain anywhere in the body can be caused by an interference field anywhere in the body. Now, are any of you osteopaths here? Anybody work? This is a concept well known in osteopathy, that a patient who has a headache, the problem could be in their left knee. A patient who has a back problem, it could be a cranial problem or a temporomandibular joint problem. In neurotherapy, it's exactly the same thing. In fact, neurotherapy was discovered when one of the Hoenecke brothers was treating somebody's osteomyelitis in the left leg with procaine injections, and suddenly her frozen shoulder on the opposite side disappeared. So any condition that you see, you have to search the whole body to look for that interference field, because the interference field is very often treatable. Now, interestingly, especially for you folks, is that 70% of interference fields are found in the head and the neck. Teeth are very, very common causes of interference fields and problems related to teeth. In fact, I go so far to say as that for an MD, it's impossible to really do neurotherapy properly without the cooperation of dentists. And I have several dentists that I work with. We trade patients back and forth. We're on the phone, emailing. The connection is so strong that in the Spanish-speaking world, there's a master of terapia neural y odontologia, which I think has something to do with study of teeth. Now, neurotherapy is best known for interference fields and scars. Now, just so you don't misunderstand, not every scar is an interference field. In fact, most scars are not. But there are enough causing trouble that finding this has made neurotherapy famous. There are many interference fields in teeth. And those of you who know the Vol charts with the acupuncture meridia going through all the teeth, you can see why they're so important. And it's not just through the acupuncture meridian, but that's a powerful transmitter of information of an interference field in the tooth. Whole viscera can be interference fields. You can have an interference field of the liver, the stomach, thyroid, etc. Somatic dysfunction, which is osteopathic jargon for an area where there's a mechanical disturbance, can be an interference field. Now, osteopaths differ from chiropractors and some other fields of musculoskeletal medicine in that they assume that there's an autonomic disturbance with every mechanical dysfunction. It's built into the definition of somatic dysfunction. So somatic dysfunction can act as an interference field. And so can autonomic ganglia. So how does a scar become an interference field? Well, the nature of a scar is that it's a result of an injury. And right from the get-go, the autonomic nervous system is involved to help repair the injury. And there's an alarm that goes out. The nervous system sends out an alarm that action is needed in the site of the injury. Now, with healing, the alarm reaction should subside, but it doesn't always. And if it doesn't, you're left with an interference field. In scars, typically they're silent. The patient feels nothing. They may have a little bit of itchiness, maybe a little tenderness, but most of the time they're silent. There's no way of knowing that it's an interference field just by looking at it. Now, here's an abdominal scar, which is an exception in that the interference field is only in this erythematous area. This doesn't often happen, but I wanted to show this just to show how this part of the scar, there's obviously a persisting alarm reaction. Here, there's none. So this scar, you only need to treat that part. They may look quite innocuous. This man had chronic headaches from a neck scar. This gentleman had an interference field in the wisdom tooth space, which was giving him sciatica. That's not uncommon. I see several a year of that. One of the reasons is if you remember the Vole chart, the wisdom tooth is on that meridian sits the sacroiliac joint. So sacroiliac instability goes with wisdom teeth. Now, this may have been contributing to it as well, some electrogalvanism, but treatment of that wisdom tooth relieved his sciatica. This lady had facial pain, and notice the little scar there. But she also had a scar from a periapical periapectomy, and it was necessary to treat both those to relieve her facial pain. Now this one I want to show you, just to show you the autonomic nervous system involvement with facial pain. This lady had a pretty wicked trigeminal neuralgia. It began with a tooth, but a sphenopalatine ganglion was involved. And when it got fired up, the gums would bleed. But it was treatable. She responded very nicely. It took a while. A lot of detoxification needed, but treatment of the sphenopalatine and the tooth and also her sinuses and her trigeminal neuralgia problems disappeared. This was not painful, but this lady had eye inflammation from an eye tooth problem. It's on the meridian. Okay, eye, liver, eye tooth, liver, and some other things. This man had a shoulder bursitis, cured by looking after that. Obviously, neural therapy wasn't the only thing needed here. This is where I pull the elbow of my friendly dentist. So, how do we diagnose these interference fields, which are nearly always silent? History is a big part. Test injections, and then there's energetic testing. So we'll get into these later. But by history, let's see. No, I'll say a few things about energetic testing first of all. Energetic testing, do any of you use autonomic response testing here? There's a few, yeah. One of my dental colleagues at home has been using autonomic response testing in his dental practice since the 1970s. So when I showed this to him in the mid-90s, he'd been doing it for almost 20 years. So I'm going to spend some time on that later. By history, think of the dog experiment, the tissue memory experiment. Remember the latent period thing? By history, when a patient comes in with a pain problem or a health problem of any kind, it could be asthma, it could be upset stomachs, whatever, I always ask them, when was the first time you had it, and what was going on in the weeks or month before that? And you have to sometimes dig. Sometimes it'll be a vaccination. You can have an interference field from a vaccination that drags a person down for decades. It can be from a surgical procedure. It could be from a bad stomach flu. It could be from a dental procedure. So when you find that latent period, that's one of the most helpful clues to determining that there's an interference field hiding behind this. I've seen it even with things like rheumatoid arthritis. I've seen rheumatoid arthritis, not a severe one to be fair, but a woman who had rheumatoid arthritis in her arms. And we were able to trace it down to a wisdom tooth problem that she'd had. And in fact, she had an infected, unerupted wisdom tooth, and surgical treatment and neural therapy, and her rheumatoid arthritis went away. Now, I'm not saying that's commonplace, but it does happen, and it's worth looking for. So, we'll spend a few minutes on energetic testing, autonomic response testing. there are many different ways of going about it. Some people will use pulse. Some people will use cranial rhythm. Some people will use electrical devices. But one of the most common ways of doing it is using changes in muscle strength. And you can use any muscle in the body. But one of the most common ways of doing it is have your patient lie on their back, have them bring their arm up like this. It's a bit of an awkward position. Have them hold their elbow very tight. Test for strength. That's your baseline. And then you go searching for interference fields. So in this case, we're looking for interference fields in the teeth. So you just go from one tooth to another. And at a certain point, if the arm goes weak, there's an interference field in that tooth. Okay? And you have to check both sides of the teeth, and you should go right up to the root. Occasionally it won't show on the tooth, sometimes it'll be in the root. So both sides of the tooth need to be tested. And you can also test for autonomic ganglia. Now, obviously, the sphenopalatine ganglion is 2.5 inches from the surface there. But here we use some principles from quantum mechanics. What we do here is when we put our finger there, we also visualize the sphenopalatine ganglion, because there's a connection that is made, and for some reason, the body will respond to these connections with an autonomic response, a change in muscle strength. Okay, so any ganglion that's deep in, you just visualize it. Put your mind on the spot. This is where anatomy comes in. The better your knowledge of anatomy, the better you're going to visualize things. And if there's an interference field there, the arm muscle strength will change. Now, it can go from weak to strong, from strong to weak, or weak to strong. It's a binary system. And here we're testing the submandibular ganglion. This is typically, if it's a dental patient, would be pain in the lower jaw or one of the lower teeth. Now, how do we treat them? Classical neurotherapy, which is what perhaps 90% of neurotherapists around the world rely on, use dilute local anesthetics. And by dilute, we mean 0.5%. There's some variation. Some will use 1 or 2%, but most people will use 0.5%. You can use lidocaine, but if you do, make sure it's preservative-free. Preservatives will irritate rather than calm. Procaine has a calming effect on the nervous system. Preservatives, steroids, and so on irritate. So make sure that your injecting solution is pure. There's different ways of going about neurotherapy. What I've talked about right up to now is focal, meaning you inject exactly where the interference field is, you infiltrate the scar, you infiltrate the tooth or whatever. There's another technique called segmental, where you might inject little, what we call quaddles, or little blebs of skin into the skin over a region. We would do this, for example, with the liver. If you have a liver interference field, which is not unusual with detoxification. People are mercury toxic. Often the liver says, oh, too much. And it goes into a dysautonomic state. It doesn't respond well. The patient generally feels tired, a little depressed, irritable. They just feel blah. They have an interference field in the liver, and you can treat those. And the classical way is little blebs, a few inches apart, over the liver, the top of the shoulder, and the eyebrow. These are all areas connected segmentally with the liver. And then there are ganglion injections, and they are directly into the ganglion. They don't have to be as precise as the ganglion injections that anesthetists use. They have to be very precise because they're looking for anesthesia. the body is much more forgiving of being, if you're in the area, it's going to work because the tissues around autonomic ganglia are all very loose tissue, and the local anesthetic can spread very easily. And all you need is a little bit to achieve your effect. Manual treatments, osteopathy in particular, but other manual treatments can treat that type of interference field. This is a big, big subject. The Europeans don't know much about this, nor the South Americans. So when I speak in Europe and South America, I spend a lot of time emphasizing that good manual treatment it goes hand in glove with neurotherapy. They both help each other a great deal. And then there is energetic treatment. Okay, before we get there, yeah, I've mentioned the procaine. Yeah, so how do procaine injections work? I've said it's not an anesthetic effect. Well, we don't really know. To be honest, we speculate. We know sodium is a sodium channel, procaine is a sodium channel blocker. We know, as I've mentioned, it's an anti-inflammatory. There's a new idea that's come up in the last 20 years. I'm hoping the speaker who follows me a little later today may bump into this, but this comes from the work of W.J. Martin, and he postulates an alternative cellular energy pathway. This is intimately connected with stealth viruses. And he's written quite a bit about this. Now, interestingly enough, this alternative cellular energy pathway responds to dilute procaine. So I'm wondering if this may not be part of the neurotherapy response to procaine. But this is very much speculation at this point. Now, this comes from the one neurotherapy textbook that has been translated from German into English. It's getting a little bit old in the tooth, you might say. And this is a famous diagram from the book, talking about what happens to the resting membrane potential. This would be a normal tissue, the membrane resting potential being well above the, what do they call it? The firing level, okay, the threshold. And if you use a local anesthetic, you hyperpolarize. And after a while, the anesthetic wears off and it goes back to normal, still well above the threshold level. Now, here is a disease cell. You'll see the membrane resting potential is below normal, much closer to threshold. So it takes much less for this cell to start firing than one that's healthier. When you administer procaine, it hyperpolarizes again, but when the procaine wears off, it doesn't go back to normal. It doesn't go back to where it was. It goes to a normal level. And what we think happens is that when it's at this hyperpolarized level, the cell machinery starts to work again. The metabolic processes and the detoxifying processes work again so that the cell actually becomes healthier. Now, often this has to be repeated more than once, but that's the goal of procaine injections and in treating interference fields with an unstable resting membrane potential. So here in the teeth, we use a very fine needle for this, a 30 gauge needle. Stay away from the gum margin itself, go up a bit. You need to do, if you're finding if you're doing muscle testing, you can do just one side. If you're not, you do both sides, the buccal and the lingual sides. Sphenopalatine ganglion is not a difficult technique. How many of you do sphenopalatine ganglion here? A few of you. For a dentist, it should be a piece of cake. You use a 2.5-inch needle, go about halfway between the ear and the eye, just above the zygomatic arch. Aim for the opposite upper wisdom tooth. So you go down and you'll go into some loose tissue. Sometimes you'll hit one of the turbinate bones. You reposition a little bit and put in about 5 cc's of dilute procaine. This one I don't recommend in the dental office. This is from the German textbook, but stellate ganglion can be really useful. Okay. I'm sorry, but that book is full of pictures like that. The model is nude from the first page to the end. And I'm not sure if they were trying to cultivate another market just to keep the book in print. It's been in print for 30 years now. Well, it's by one of the great contemporary neural therapists, Peter Dosch. His father was the author of the classic book that I just showed you before, and the son did the manual, just all the injection techniques, and there's 70 pages of them. So I have gotten away from procaine injections, started slowly about 15 years ago. Now I hardly ever inject because I found energetic treatment works just as well. And it's much easier on the patient, much faster. Patients like them. And there's more than one device out there, but this is the one I use. It's called a TENSCAM. This was invented by a friend of mine. He's an osteopath, orthopedic surgeon, very, very skilled cranial therapist. He's retired now. But it's a very simple machine. It has a Vogel crystal in it. It has a copper winding around the crystal, and then it has a pulse generator. And the pulse that generates is 8 hertz. 8 hertz was chosen because 8 hertz is the Schumann resonance. Does everybody know or does anybody know the Schumann resonance? Okay, Schumann resonance is a resonance between the ionosphere and the Earth. It's going all the time at 8 hertz. It's probably involved through our pineal gland setting up our pulse generators for our biological rhythms. Vogel crystal was used because crystals seem to have this effect of amplifying intentionality. This comes from quantum physics, where your intention can change things. But by putting this copper winding around it in a pulse, what it does is it acts as a intention amplifier. So when we're practicing as dentists or physicians, we think that everything we do is the things that we do. But really, probably the most powerful thing we do is our intention to heal. It's in the background. We don't talk about it, but it's. Thank you. This is the right audience for me, and this is what this tool does. So, with this is my secretary receptionist, by the way. She's a really good sport. I've had her for 25 years. So here she has, for the purposes of this picture, she has a problem in one of her teeth, and I know what tooth it is, so I'm visualizing it, and I'm turning on the light here just to show. You don't really need to do that, but I'm treating, say, that tooth there. You use intention, 45 seconds, a minute, and it's treated. You go back and you muscle test, and there's no response. Now, not all teeth are going to respond in one treatment, but often they do, or sometimes they do. Here, Okay. Typically, what I do, if I have a patient who has a sick tooth, some infection or an irritable root canal and so on, I'll treat them once, I'll have them come back in 3 days, test them again. If they still have the interference field, I treat it again. I tell them usually we're going to do it twice a week up to 3 weeks. Most of the time, 1, 2, or 3 sessions do it. Occasionally, we're into the 3rd week. Only once in the last 10 years have I had anyone fail, and that was a patient that had a full-blown cellulitis. So it's very effective, very simple tool. Now, these TENSCAMs are expensive, so you might just do the procaine injections, if you don't want to invest in this. But you might decide to invest in this because it does some other things as well. Now, when you have an interference field in the tooth, often there's an infection there. And the way you can tell, other than looking for inflammation, is you can use a homeopathic that's related to infection. There's a variety of them that you can use. And if, when you put the homeopathic in the field, the muscle response changes from weak to strong or strong to weak, you know there's an infection in that tooth. And you're going to use that homeopathic to treat it. All you need to do is you hold the vial of homeopathic over the tooth. It doesn't have to, in fact, it can be over the face. Then you send your TENSCAM signal through it, and it treats the infection. Okay, very effective. Now, I know we're not talking about infections like Dr. Malika was talking about yesterday. That's a different class altogether. But your garden variety pains that come into your office, or some of them land up in my office, this device is a wonderful tool for treating dental pain, facial pain, and so on without needles. So, summarize. Chronic and recurrent pain begins with a focal irritation of the nervous system. Speransky felt that all diseases began that way. The pain experience is often a summation of past and present neurological inputs. So that input that you're getting right now, the elephant in the room might be the tissue memory from years before. And we can change these things by upregulating and downregulating the autonomic nervous system. And neural therapy's job is to normalize the autonomic nervous system's tone at the interference field. So, 1 hour, 33 seconds.